Hello, everyone, and welcome to this very special edition of the Research Roundtable. My name is Kyle King. For those of you first time joining, maybe tuning in, I'm a rising junior at Yale University studying neuroscience. I myself have OCD, and ever since I really received my diagnosis, I've had a lifelong interest in understanding a little bit more about OCD, but I know that reading the literature is complicated. So I really wanted to start a program where we could talk about the literature with someone who knows it, like Dr. Moreno and Dr. Abramowitz on with me today, in a way that everyone could understand. And as always, I'm joined by my co-host, John Abramowitz. John, if you want to introduce yourself.
Thank you, Kyle. Sure, I'm John Abramowitz, and I am Kyle's sidekick on these. And we've had a fun, what is this, our seventh, eighth one now?
Something like that, yeah.
Yeah, something like that. But I'm a professor at the University of North Carolina in Chapel Hill, and I study OCD, and I work with folks who have OCD in my clinical work, and teach graduate students how to be the clinicians and experts on OCD of tomorrow. And we are very grateful to have our guest here to talk about a very interesting and kind of it's just
kind of
new and at the same time not really new, but I think this is something that's garnering a lot of attention recently, so it's very timely. Dr. Moreno, do you want to introduce yourself?
Yes, absolutely. First of all, let me start by thanking you both, Kyle and John, for inviting me to join your show. And I'm excited to be here and be able to share with you a little bit of our experience and some of our understanding about OCD and some of the treatments, the new treatments that are being explored in the pipeline of potential interventions right now. I'm a psychiatrist also, and I do a lot of other things in my professional life. I only do clinic and psychiatry for 1 day a week. And I also do research with other types of work related to genetics and a little bit of clinical research. And I'm also very interested in training. So I help training of residents, the people that are going to be psychiatrists and early career investigators. And I also work in the space of equity, diversity, and inclusion. So I have some programs to help increase the diversity of the pipeline of researchers and clinicians so that we can help take care of needs of everybody in our country. So again, thank you for the invitation. I look forward to our chat.
Awesome.
Yeah, thanks for joining. I will, before we get into the discussion, I just want to say I am vertical and my camera's probably shaking a little. Full disclosure, I'm like in a hotel on the streets of New York. I was trying to get back to the hotel room that I'm actually staying at. But the trains were like broken down and stuff. So I'm kind of in a weird situation, which is why I said it was a special edition of the Roundtable. But I also didn't want to miss this because at Yale, our clinic is doing a psilocybin study. So I've always been really interested in learning more about this. Plus, I have friends who have asked me about a lot of questions about psilocybin. So I wanted to learn a little bit more. John, before we get started, do you want to do the announcements?
Happily, and I'll just say that at UNC Chapel Hill, we're also gearing up. I think it's part of the same study that is being led out of Yale. I think we're a site at Chapel Hill as well. But as for announcements, yes. So this live stream is educational, and it's not intended to replace therapy. For treatment-related questions, please work with your provider or contact a local clinician. And you can use the IOCDF's wonderful resource directory at iocdf.org/find-help. to locate a trained clinician near you. And the International OCD Foundation is not a crisis hotline. If you're in a crisis or you're ever feeling suicidal or unsafe, please go to your local emergency room, call 911, or call the Suicide Prevention Hotline, which you see the number on the screen there, 800-273-8255. And we want to create a safe environment and be kind and respectful to everyone. So at the end of the day, we're all here to support one another, of course. And so this show is being broadcast and recorded on several social media platforms. So just be mindful of questions you write in. Those are being also recorded. A couple of other announcements from the IOCDF. On Tuesday, join National Advocate Ethan Smith for a brand new Community Conversations live stream at 7 p.m. in the East, 4 p.m. in Pacific time. Registration is open for the annual IOCDF Research Symposium in July, and we invite researchers and students to share data and findings from their latest OCD-related research. And this year's symposium is going to be a hybrid of both in-person and online events. So you can go to iocdf.org/symposium to learn more and to register for that. I'm doing that. That's going to be really cool. And registration is open for the 27th annual OCD conference, right? The IOCDF National Conference. That's also always really cool. And I can't wait to do that and be there in Denver in July. And this event is for the entire OCD and related disorders community, people with OCD, family and supporters, therapists, researchers, everyone. iocdf.org/OCDCon is where you can learn more and register. Finally, join us for the 1 Million Steps for OCD Walk this June and in October. Find a walk near you and register today at iocdf.org/walk for a day of community advocacy and fun. Finally, well, not really finally, but in closing this live stream.
2 finalies, John?
I got a lot of finalies. We have a lot of announcements this month. This live stream is one of many. You can see the entire schedule and submit questions and suggestions for future streams at iocdf.org/peace of mind. You can also view recordings of past live streams on IOCDF's YouTube channel, youtube.com/IOCDF. Remember to like and subscribe to get notified when live streams are scheduled. And to be notified of when we're going live, follow the IOCDF on social media and subscribe on YouTube. And if you need resources, please visit iocdf.org. Ha! That's a mouthful, but important.
All right, you got through it.
I got through it. Thanks for bearing with me. Let's get down to the business of psilocybin and learning about OCD.
So I have my first question. But as we discuss, everyone feel free to pop questions in the chat. But first, John, you kind of touched on this, how psilocybin research it's new, but it's also not new. So Dr. Moreno, what's kind of like the history of psilocybin in psychiatry? And what is psilocybin really?
Right, great way to get into it. So psilocybin, it's a substance that is the main compound that is found in magic mushrooms. There's all kinds of mushrooms, but the ones in the genre of psilocybin are mushrooms that have been used medicinally and also in sort of traditional and religious ceremonies for millennia, really. So it's been used to support spirit and wellness for thousands of years, and especially in cultures throughout the world, but in Mexico and parts of the American continent, this is where we have perhaps the most visible sort of track of narrative that describes its use. And so the substance itself, it's very similar to our brain chemical serotonin. As the audience is familiar with, serotonin is commonly implicated in the mechanism for OCD and the mechanism of action for a lot of the medicines that are used for OCD, like the serotonin reuptake inhibitors and whatnot. And so psilocybin actually works by blocking a serotonin receptor and activating a serotonin receptor, and it has a particular connection in some brain regions that have also been implicated with the neurological basis for OCD. So it is nice in the sense that we have a naturally occurring product that actually binds to the brain areas where OCD sort of is supposed to be taking place, and it actually does something similar, or at least using the same machinery than the medicines that are currently approved for OCD work. And as we all know, the medicines that we currently have can help many of us, but not everybody. And sometimes the help we derive from those is partial, and we want it to be more. So we're always hungry for new options that can really expand our current understanding and perhaps facilitate the development of new therapies.
So SSRIs, as I understand them, act by like increasing serotonin in synapses and then increasing the amount of serotonin that's locking into neuroreceptors. Is psilocybin binding to serotonin receptors, or like what is the mechanism of action? And also, what were those brain regions you mentioned implicated in OCD that psilocybin acts on?
Yeah, so of course, very good question. Also, yeah, the SSRIs and some of the not so selective serotonin reuptake inhibitors, like clomipramine, and some of the SNRIs that are also used in OCD, increase the availability of serotonin in the synaptic cleft because they are blocking the reuptake, so the drainage of serotonin back into the cells. And so there's more serotonin available so that the postsynaptic receptors get the actions of serotonin. So it is very complex in the sense that it's not just about how much serotonin you have, but which receptors get activated or maybe inhibited or eventually downregulated, and what happens in those postsynaptic cells. And what we know is that the use of these medications leads to intracellular changes that may produce early gene expressions and changes in substances that sort of help regulate the function of various brain regions, like neurotrophic factors. That these are kind of like substances that help regulate again the connectivity and the vitality and the connections of neurons in different regions. And some of the regions that we were thinking about is parts of the frontal cortex and the orbital frontal cortex, the anterior cingulate, and some of the basal ganglia also that have been associated with the corticothalamic striatal system in OCD as well. Yeah.
Mm-hmm. And you mentioned that kind of in the past it has been used medicinally. In the 60s, or that's kind of when I associate psilocybin being big, was it used in psychiatry? Or like what is the more recent history of psilocybin in psychiatry?
Yeah, so psychedelics like LSD and to a lesser extent also psilocybin had been explored and utilized in clinical context about 50 years ago. And eventually they kind of fell out of favor and they were not utilized as much. And after about 30 years of not having a whole lot of research, there was gradually an increase of interest and increase in activity in psychiatry, but primarily doing basic science work in the 90s. And by the early 2000s, there were a couple of protocols that some of our colleagues had been working on, including protocols looking at people that were dealing with the existential anxiety of end of life due to having a terminal illness, the explorations of healthy volunteers to really learn a lot more about how it worked in the brain, and also the work in spirituality that came out of Johns Hopkins also in the early 2000s, and the work that we had started doing also about 20 years ago with OCD as well. So those were some of the first clinical application trials, whether with patients or with healthy volunteers to inform that effect, or with animal models to inform those effects as they got started. And then subsequently, we started seeing more and more recently an expansion of some of those trials until we have more recently seen a very large scale involvement of clinical research at a lot of the mainstream clinical research operations going on at the main universities in our country and outside of the United States.
John, you're in your question pose. Do you have a question?
Oh no, I'm listening intently. Yeah.
All right. So you mentioned kind of psilocybin's use in anxiety, and I'd also read prior to this that it was really big in depression, or at least it's been investigated in depression. So before we get specifically to OCD, what does kind of the general psilocybin research look like with regards to other psychiatric disorders like depression and anxiety?
Yeah, so psilocybin, it's and other psychedelic substances engender or occasion a variety of different experiences that people would have that perhaps allow us to really connect with some very profound issues that we may be having. So I'll use the example of the end-of-life existential anxiety, some work that has been done in various states around our country. But one of the thinking behind it is when you're having an experience with psilocybin, you may be in a state of mind and your overall kind of complex relation to it that allows you to connect with mortality and see death and dying with a different light, perhaps gain a different perception as to life as it ends and what happens. And this is sometimes a little difficult to explain. Going through one of those experiences gives you a very different perspective on those issues. And so our relation, the anticipation of death, the fear of death, the concern with death, it changes dramatically for the individual who goes through that experience in a significant number of cases. And so folks that were very anxious and apprehensive and fearful and disappointed may have a different perception of what the end of life actually means to them and to other people, not only themselves.
So kind of following on the end of life example, is you take the psilocybin, and do you take enough to have hallucinogenic effects, or is it more just like enough that you're thinking differently?
It is, that's also a very good question. So psilocybin, depending on the dosing, depending also on the individual's state of mind and the setting where you're at and the preparation that you have had for the experience, may kind of take you on a continuum of the intensity of that experience. And there's also different qualities to that experience that people can have. And so often associated with the higher doses, there may be a feeling of comfort and relaxation, but at higher doses, people can have this changes in our ability to connect with aspects of our mind that are often outside of the reach of what we allow ourselves to have. And so you may be having not an experience, not only when you're allowing yourself to think about death, but perhaps you're actually experiencing aspects of death. And that may be a little difficult to explain, but it is something that can happen to some people in the process of having an alternative state of mind, right? An altered state of consciousness, as we sometimes call it.
And is your sense that it's more the serotonin properties or more that kind of consciousness effect that is influencing OCD, for example? Because a lot of people with OCD, they think about death, they think about existential stuff.
Yeah, that's a very good question, and it's very difficult to separate serotonin from the experience that people are having, because it has been correlated, the intensity of the experiences that people have with the amount of occupation of the receptor by the drugs that people are ingesting. Okay. And so it's hard to say, when does the drug start and when does it end? But it is usually through the effects facilitated by the medication in an individual that one can get to those states of consciousness that are different to what we're used to. And sometimes it's very difficult to talk about them because we're coming up with some esoteric and strange terms and pretty noetic ways of looking at stuff that people are not used to bringing into our everyday conversations.
Got it.
So I kind of want to turn to OCD, but before I ask a question of you, Dr. Moreno, John, how do your patients ever like bring up psilocybin? Because I know like I do screens for the OCD clinic at Yale, and there's a lot of interest in our psilocybin study and getting involved in it.
I have had more bring up ketamine, which is kind of showing up in the comments now from some people. I haven't had too many people raise the, ask me about psilocybin specifically. So it might just not be as well known or permeated in the literature.
I know I've been asked about it a bunch. Also, John, I can't see the chat, so if there are questions, feel free to ask them.
Oh, okay, sure, yeah.
But okay, so in OCD, before I ask you like specifically kind of the state of the research and whether it looks promising, when you attempt to do these studies, you're looking for a decrease in YBox, right? So you're looking for a general decrease in symptom severity.
Yes.
So you give the dose that alters the consciousness, and then what happens after that? Because it sounds like there's a therapist there and you're guiding kind of an experience.
Yeah, so part of what we do is we have provided in our studies different doses of psilocybin. And so the amount and the quality of the experience will vary, of course, depending on the circumstances that we talked about. And we usually, we're sitting in a room with a couple of facilitators. We call them sitters. And these are, in our group, it's included one credentialed provider and an individual that has training that can help address issues that may come up during the session, and they facilitate safety and a supportive environment, but they're not themselves providers. And so it's often, whenever possible, people that have had a very good opportunity to connect well with a person. So there's no new faces and no people that may have the wrong vibe with the people in the room. So it's usually a very supportive and comfortable environment. And then we basically tell people after they use the medication, after they ingest the drug, and it's usually double blind or double masked, which means they don't know what they're taking and we don't know what they're taking. It could be a placebo or a different dose. And so we ask them to actually put on some blinders and, eye covers. We also give them a set of headphones. And we do that in an attempt to really avoid the distraction from the external environment, make sure they're not on the phone, that we're not distracting them. And we really tell them to take the experience inwardly and whatnot. And so they will have for many hours, an opportunity to be in the room, a comfortable couch that can turn into a bed. And they are watched by us from the outside while they're having their very internal experience. And
so
we may intervene.
So you as therapists aren't like actively asking the participants to think about their obsessions or do exposures per se. They're just kind of sitting there thinking about it, like reflecting on themselves as they want to.
Actually, yes, we do not give them homework assignments. This is not a therapeutic intervention. This is a facilitated experience. And we actually, speak about following the experience as opposed to steering the experience. We don't want them to be resisting and keeping themselves from going to think or feel or live whatever is coming up as a result of the ingestion and their presence in the room. And we find that often, when you're following the experience and really getting into the experience is what may facilitate a greater, a more rich and robust type of experience for an individual. And we're not doing psychotherapy while people are in their dosed state, but we may be doing sometimes supportive interventions if we need to. If somebody's having some period of anxiety or discomfort, we may listen, we may work with them. We may change aspects of the environment, like maybe change music, or maybe get the lights on, or ask them to take off their mask, and then we just to make sure that they're doing okay and feeling that they're able to continue.
Yeah. I gotta say, I don't know if you're surprised, John, but I'm kind of shocked that I was under the impression it was they take a dose and then there was like a very guided approach to what they're thinking about while they're kind of have this altered consciousness. Does it ever happen where like someone just doesn't think about their OCD? Like, why does kind of allowing someone to just sit there in this state end up affecting OCD?
Yeah, and again, that's a great question, and we tend to think of the interventions we make as being what really facilitates transformation in individuals, but many times there are change that happens that is fairly unrelated to the process that we bring in for how we understand therapy and treatments work. In fact, we do not know what forms of therapy may be best for folks. In the context of depression, for example, and PTSD, for PTSD particularly, sometimes the dose and the drugs that are used are to facilitate perhaps having access to those memories and events that may be very difficult to deal with otherwise. But when you're really using a full psychedelic dose, you do preparation and you do the facilitation and then you do the reintegration later, really keeping in mind the value of the experience itself, as opposed to just using it as a tool to do therapy right or to break through some defenses at the time that you're working with the individual. In fact, it's not the best time to be doing, when you have somebody in a high dose of a psychedelic agent, it's not the best time to be really, right, challenging those sorts.
Right. Yeah. They're not going to learn. They're not going to do exposure therapy and consolidate learned information when they're having an experience like that. We have an interesting question from Lisa, who back at 1218 asked, has pharmacogenetic testing been done on psilocybin to learn how people respond to the drug? And is pharmacogenetic testing incorporated into the current research, including the potential for adverse reactions and events?
Yeah, that's a great question, Lisa. There's been, we have not done that. And I have a student working with me right now that is interested in doing that aspect of things. We had a small lab where we did phenotyping for specific receptors like HTR2A receptor, which is, there's different predictors of tolerability and outcomes for this medication with the use of SSRIs, for example. And so it's easy to anticipate that some of these changes may be, of course, mediating the degree of both the response to psilocybin in terms of the experience itself, as well as the therapeutic benefit that may be derived from those agents. And so that's really a good question. The difficult challenge here is that you really need larger numbers of individuals that are participating in these trials. And that's definitely something that I think we're going to be seeing more and more as we see larger numbers of folks exposed to these types of treatment. But that's definitely an interest of us. And in addition to the pharmacodynamic related genetic markers, there's pharmacokinetic related markers also that may inform the speed of breakdown of certain agents, like psilocybin actually breaks into psilocin, which is the active compound that is most likely responsible for all the clinical and experiential benefits.
Okay, now I want to jump into kind of the meat of all of this, which is, from what we know now, and I don't really know how many studies have been done. You can answer that question better than I can. How does psilocybin look? Does it look promising? Does it look like there's beneficial effects in OCD?
Yeah, so there's not a whole lot that has been published in terms of the controlled clinical trials, but we have known for a period of time that based on anecdotal reports, that people that have used psilocybin or LSD or mescaline and other substances with a similar mechanism of action, that it may help some people with OCD and even conditions before we had OCD as a term in DSM, like obsessive neurosis and whatnot, and also other obsessive OCD-like conditions like dysmorphophobia and whatnot. Have there's been some reports of that benefit. We published our first paper on the outcome of psilocybin given prospectively in a clinical setting in about 2006. And the time we gave a number of individuals different doses. And we had started with low doses and escalated a little bit to the fully psychedelic dose, and then inserted blindly a much smaller dose that it was, in our view, going to be the placebo. And so the exciting thing at the time is that actually people did a lot better after the exposure to psilocybin. And the not so good news is that even the very low doses gave people a very nice experience. Not a nice experience in terms of the psychedelic experience, but a good anti-obsessional response when measured within 24 hours of the ingestion. Now we know that microdosing or using very low doses that are not fully psychedelic of the different psychedelic agents actually has beneficial effects, at least immediately, for anxiety, for mood, for a variety of different things. And there's a lot of anecdotal reports of that. And but at the time, we knew less about microdosing. And so we used a microdose as a control, which nowadays we wouldn't do. There's been since then a number of initiatives going on in the United States and elsewhere. We are conducting another study. We're about to finish another pilot using low dose, high dose, and active placebo with benzodiazepine. And other folks, as you mentioned, Kyle at Yale, we had your team doing a single low dose trial, and now they're ready to do the repeated doses. There's initiatives also going on at Stanford and outside of a number of places here in the US and Canada. There's a large initiative going on also in Israel. There's work going on in Australia, several European countries that have an interest in looking at the effects of psilocybin at facilitating aspects of ERP or perhaps ACT in the use of augmentation of the psychotherapeutic interventions.
I have two questions, but my first was going to be a methodological one. What is the appropriate control? Because people are going to easily guess that they're on this if it's compared to an inactive placebo, which we see a lot of in psychiatric drug testing, but we don't see. But I mean, I'm curious, how would we control for that psychedelic effect?
Yeah, that's a great question, and that's a question and a challenge that plagues the field. Mm-hmm. People have used anywhere from substances that give you sensations related to what sometimes people see with psilocybin. We've used the different doses to try to mask this, and other people have used either a stimulant or a sedating agent that may give you some way of trying to mask. But it is very difficult to mask the very extraordinary experience of a high dose on some individuals. And so I have to say that is a challenge. And the narrative among colleagues is that sometimes you can mask the low dose versus a placebo, or the low dose versus a high dose, but it's very difficult to mask a high dose to a low dose. And I've seen it happen in which some people don't think they got anything, or some people, they really feel they got something when they really did not. But it is difficult. You are right. In the aggregate, the majority of individuals are going to be really aware that they're going through something truly extraordinary.
Yeah. So my second question has to do with just availability. A lot of people in the chat are saying, where can we get this? So where are we in terms of whether it takes FDA approval or even off-label? Can talk a little bit about where we are in terms of being able to go to your local center and get, whether it's, low dose, high dose, microdose.
Sure. Well, let me preface my response by saying that I'm holder of a DEA license, and part of my deal with the DEA is I'm not supposed to be helping people use underground psilocybin or be informed as to how they can go and grow their mushrooms or buy them at the market. There's states in our country where the use of psilocybin, it's either legal now or about to be legalized, and so there's a lot of sort of citizen-driven kind of research, and some real thought leaders in research coming up with ways of attempting to collect large-scale data by people that are using themselves, particularly microdosing, that could be collected, that we believe is going to be important information as well. That I like to say, I'm a true advocate for research with psilocybin agents, and so I want to make sure that we continue to do very responsible, thoughtful, protocol-based approaches so that we can learn a lot more about the use of these agents. And I hope that it will be that route that allows us to soon be able to have access to these agents. The MDMA for PTSD and psilocybin for depression have this expedited path through the FDA that may allow us to get this. And so many of the folks that have OCD also have depression or other anxiety conditions. And I imagine that there's going to be quite a bit of opportunity for folks to use. And similar to ketamine that you mentioned, this was approved for depression or TRD, and then it's become something that has been used off-label, but in the context of responsible practitioners and research institutions has been expanded and explored in OCD a lot better. So I believe the shortcut to us being able to use it in OCD is going to be when we get approvals for other uses. There is definitely a growth in the training of individuals that can do therapy with psychedelics. The field is really ready to take on its implementation when the time comes. I caution people, this continues to be experimental. We want to make sure that this is safe and effective, and we want to give you the right information as the data continues to come. I'm very optimistic and very excited by the early results that we continue to see all over the place. But again, one has to sometimes contain that excitement. There's a reason why we do science the way we do it, and I'll say, look for protocols that continue to be available in various parts of our country, and more to come.
It's good to hear you say that. For people who have watched our show before, I tend to, my initial response is skeptical to most anything. Like, show me the data, show me the evidence. So it's good to hear that the people doing this research are also feeling the same way, so that when we've got good results, it's because we've done very careful, controlled research. So that's good to know that that's what's happening. Sometimes these things get rushed. Yeah.
Especially when it's something exciting like a new treatment.
Yeah.
I want to drill down a little bit more on what the results look like. And I know it involves kind of understanding the YBox. So real quick, John, what's the YBox? What do scores on the YBox mean, just for people who may not know?
Sure. The YBox stands for Yale-Brown Obsessive Compulsive Scale. And as many people might know or might not, this is kind of the gold standard way of assessing the severity of OCD. It can be done usually in an interview, but it can also be where the person is, filling out a questionnaire. It's 10 questions. And your score can go from 0 to 40. 40 means you have very severe OCD. 0 means you don't have symptoms at all. And usually folks about, around 10 or so and higher tend to exhibit, observable symptoms of OCD that require some sort of treatment. And usually if you're above 17 or 18, you qualify for research.
I'm glad I saw Dr. Moreno take a sip of water. I felt bad. We kept bombarding him with questions. But there's another one coming. So I know in your 2006 study, you measured people's YBox scores, I think before the dosing and then during the dosing and then maybe after the dosing as well. What do YBox scores look like as you dose, as you go through this experience? And how does it differ depending on whether you take the high dose or the low dose or the extremely low dose, all that stuff?
Yeah, that's a great question. And so, again, the previous study that we did about 27 different sessions divided among 9 people. 2 of them only did the first dose and didn't come back for the other doses. At the time we were doing this, we were keeping people in the hospital overnight in a psychiatric unit, and that was very uncomfortable for some people. That was the main reason why they didn't want to come back, a couple of the folks that participated. So everybody received the first dose that was a 100 microgram per kilogram dose, which is maybe similar to a low dose that is used in current trials, a single-digit number of milligrams. I can say that the majority of folks in the various doses that we offered in the 2006 study, they all came in with about moderate to severe range, so mid-20s and higher, as opposed to just mid-teens. And many of them had very dramatic improvements, almost going to, a number of them went to 0. And a number of people stayed at 0 by the next day. So we would rate people in the morning before they take the medication, 4 hours, 8 hours, and the next morning. And that was one of the limitations of our study, that we didn't keep measuring prospectively very carefully. Although, we have what we have learned from ketamine, for example, is sometimes you get a very nice response and it will last like 3 to 5 days, maybe a week, and then you have to be dosing it again. But repeated doses may change the outcome for individuals and whatnot. And so we now have a study in which we're doing repeated dosing, and it's too early to be talking about the results, but are the questions we're still trying to find answers for is, we know that the various doses are going to be leading to decreases in severity of OCD, but which doses may predict the sustained response in individuals. And in the current protocol, we actually rate people daily for the 8 weeks that they come. We actually do 8 sessions, and some of our people receive as many as 8 doses of psilocybin. And so we've done north of 100 doses, of course, by now in the current protocol. And of course, we still need to find out, once we break our blinds, whether or not the low dose is sufficient enough to sustain a response or to cause the electrophysiological or neuroimaging changes that we anticipate may mediate the response. And just looking at baseline to end of study, we're just very encouraged by what we're seeing. But we would need to be breaking the blind to really learn a lot more about that.
And have there been other double-blind studies that have found, it sounds like your effects were rather encouraging. Do other double-blind studies show kind of similarly encouraging results?
Again, there's not a whole lot that has been published. And the narrative is for a number of conditions, not only for OCD, that this is something like we haven't really seen much before. So very encouraging in a number of ways. And even the low doses seem to have a nice, at least temporary impact in scores. So we're optimistic about that.
Yeah, and is there any sense of, like, I know in ketamine you come back for repeated dosings, I believe in depression. So did the effects of the psilocybin in your study, did they kind of stop as you move to the 24-hour time point? Like, was the dip in YBox the most significant right after dosing, and then it kind of crept back up to wherever the patients were? Or was it kind of constant until the 24-hour time point?
So I can speak about the one that was published already, and people really remain well way beyond 24 hours. There's a period of what people describe as the afterglow of psilocybin or LSD, and it lasts several days in which you're feeling things differently, thinking about things differently. That in itself could be a really nice window for a lot of the psychotherapy that we talk about, in which there's still a whole lot going on that is not exactly reaching the threshold of a very altered state of consciousness, but people are feeling differently and thinking differently and experiencing things in a different way. And so definitely now we have folks leaving our research center in the evening. We don't keep them in the hospital anymore. And so we'll have different environments. Some of our environments are very supportive. Some of the environments could be very stressful. And so that will also impact how people are doing. But in general, we can tell that the effects of the drug itself, if we lived in a vacuum, this will be really beneficial, lasting longer than the 24 hours. And the real question for us is how many doses, how high of a dose, how often do we need to repeat them? And that's something that is going to take us a long time to really find out. But we're starting with a very optimistic perception that there is really the capacity for change, that we work with folks that have never had days where they are free of symptoms in decades sometimes, and all of a sudden they get to have an experience, and it's like they now recognize and they can do a lot of relearning during that time as well.
And like from a theoretical perspective, sorry, this kind of still baffles me. It's just kind of like you take this drug and then like it's unclear what changes in the mind or in the brain, and people just see this reduction of symptoms.
Yeah, it is still unclear. I'm sorry, what changes, but we know the tradition of healing with psychedelics may involve real transformational experiences that really change people's views of things and experience of things. This is not the way in which we're accustomed to speak in psychopharmacology. We're used to see changes and then go back and really learn more and measure to see if our theoretical proposal makes sense and if what we hypothesize can be tested. There's still a lot of we need to learn in terms of how these agents work, but again, a lot more to come. There's been a number of interpretations of how this works from what we have heard in depression protocols, and there's more to come from the work that folks at Yale are doing and in our institution as well.
Sorry, I was muted. I know John has a question, but I don't know where he went. So before he gets back,
I'm back. Yeah, sorry. So I'm sending Skyla like ideas for questions from the comments, and I keep hitting the wrong button. So I apologize for that. So, and I was going to kind of dovetail, Kyle, into what you were saying. What's your sense that this is something like we're masking the symptoms of OCD? We're giving people these experiences that kind of takes them away from, their worries for a while, whether it's a day, sounds like it might be longer. What's your sense that that's kind of the mechanism?
Yeah, that's a very good question. And that's part of what we need to really substantiate with data in the long run. And so in addition to measuring people daily during the trial, we measure them, as I mentioned, for 6 months after that. There's no way that people are having a good experience 6 months after that. And the data that we see at 6 months, I think really argues against that. And, we measure people weekly for a month, then monthly for 3 months, then at 6 months. And if you look at the clinical trials for the SSRIs that have been published, you would see that the YBox, the main outcome scale that Kyle and John were talking about, drops by a proportion. Sometimes we call a responder a person that has a 25% drop in the severity of the YBox. Sometimes we call a remitter somebody that drops 35%. Try 75%. Try 80%. Try that at 6 months. That cannot be just a good experience that they had on a day at a nice tripping couch.
Yeah, right.
So those are very different outcomes.
Yeah, and this is just something that I've always wondered. Well, I guess I have two questions. I have so many questions about this. First, how safe is it? I'm neurotic. I don't want to try medication that I'm going to go in and have a bad trip and then have a terrible experience. So what do patients talk about? Is it safe? All that kind of stuff.
Yeah, I think, that's an absolutely perfect question. A lot of our people that are dealing with OCD are very risk averse and very concerned about the side effects of the medicines. In fact, we also get a lot of people that want to try psilocybin because they don't want to be on an SSRI or an SRI or an augmentation with a different agent. These are real issues. These medicines are associated with sometimes uncomfortable experiences, challenging experiences. And so that's part of what we work with people to prepare them for and work with and work through. Sometimes the challenging experiences could be where somebody is, in touch with thoughts or, kind of living an experience that is very anxiety provoking for them. The tradition in people that have done a lot of psychotherapy in folks using psychedelic agents is that many of these difficult experiences actually are the ones that may predict more robust benefit for individuals. I mean, that's something that still needs to be studied further. There's some reports of the how much that could actually facilitate or mediate transformative type of experience for somebody. But we do ask people to don't move away from things that appear to be uncomfortable. Don't run away from that particular thought. Maybe stay with that a little bit more, see what we learn in the experience as we go through it. So it takes a fair amount of preparation and comfort. This is not for everybody. And I think the more we learn and the more we hear from peers and other people that says that was really good or whatever, it may facilitate the comfort for other individuals. But I think we're going to have initially some people that are more comfortable with the thought of trying something like this. Eventually, as we are able to utilize this in clinical practice, I imagine that we may really have an opportunity to do what we do in practice now, which is to start with different dosing and find individuals to get comfortable, and then explore, what elements of the experiences are necessary. Do you really need a full dose? Do you need to have this altered kind of states of consciousness to get the right response? Did you need to have that to sustain the right responses? These are all questions that we're still all trying to make sure that we address cautiously.
And the patients that are in the studies, these are folks, I'm assuming, that have they've tried other sorts of treatment first, or can you be in a study or even be appropriate for the medication if you haven't tried the more routine kinds of treatments?
Yeah, excellent question. So for our study, what we decided to do was to invite individuals who had failed the standard treatments for OCD, at least one failure of standard treatment interventions, whether it was SSRI or CBT with ERP. Yeah. And so the majority of individuals have failed both, a number of them. A lot of people that have not tolerated an adequate trial, but have had adequate trials as well. So it is for people that have at least one failure on standardized guidance concordance treatment for OCD.
Cool.
Yeah, and you talked a little bit about kind of like the more mental, I guess, if you will, safety, like how people experience the psychedelic trip from a more physiological perspective. Is this safe?
Yeah, this is a very safe substance. If you look at, there's different terminology used in pharmacology and medicine, and there's a scary term called the lethal dose 50, the LD50, which is, what is the dose that people will need to take so that, it will lead to death. And the LD50 for psilocybin, it's an incredibly high amount. And if you look at all the medicines that we use now ranked, it's safer than, of course, aspirin and Tylenol and some of the vitamins that we ingest every day. I mean, having said that, this medicine can have a variety of side effects because it does work on receptors that also interact with a variety of different physiological functions. And so we're always cautious to make sure that we're not bringing in people that may be at risk of arrhythmias. And we check an EKG and make sure that that we are keeping people safe that way. There is an increase in sometimes heart rate and blood pressure that happens as a response of the medication. And one of the most maybe uncomfortable physiological responses to the medication can be gastrointestinal discomfort, like nausea or whatnot. In some cases, people will vomit or they will ask to pull the bucket, although they may not get all the way to that. And so those are, in terms of the tolerability, things that could happen to folks. The experience itself, sometimes there's a lot of emotionality, that people could be going through. And when people talk about a hallucinogenic, we often think, oh, I'm going to be hallucinating right and left. And it often, most of the time, it really includes, the perception. And of course, people have their eyes closed and they have eye shades where they're going through the highest dose. That is with your eyes closed, and so it's almost like things are sort of perceived through your mind rather than through your eyes, and you are, of course, going through a complex experience that doesn't involve just the appearance of a vision here or there, but is rather a narrative, a history, like you're going through a vignette of something, and that's part of why people call their trips, right? You're tripping on something. And the contents can vary a whole lot. And there's a lot of sometimes common themes that have been described by other people that is kind of beyond the scope of what we're covering today, but definitely could include some uncomfortable periods as well.
So not going to kill you, but certainly will bring on the altered state of consciousness.
Yes, that's likely to happen. And of course, we make sure that we avoid other medicines that can combine with it lead to altering the availability or the efficacy or the risk associated with the agents as well.
Yeah, and we're about out of time, but actually someone I think way back had asked what medications are there that come to mind. What are the biggies that might be contraindicated when psilocybin would be contraindicated because the person's taking these other medications?
So right now we have really excluded people that are taking serotonin reuptake inhibitors because, the thought has been that it may minimize people's likelihood of having a full experience and a response, or maybe increase the risk for serotonin syndrome. So things that act in serotonin are thought to maybe increase that risk. Yeah. That's based on the little evidence that we have, and there's a lot more that we can learn. And I imagine in the future, some of those common practices may be modified. We also would not combine them with things that block serotonin too, because that is thought to be the mechanism by which these medicines work, and so it will nullify the activity of the medication. At least we believe that's to be the case.
All right. It is a little after 1, and we need to be respectful of people's time, but this has been really enlightening. I've really enjoyed our conversation. I learned a lot today.
I've learned a lot.
Yeah.
And that's coming from someone who works in a clinic that's doing a psilocybin study.
Yeah. Yeah.
Well, I'm glad that we all had a chance to learn a bit, and thank you very much for the opportunity to connect with the audience and members of the IOCDF Foundation. That I want to say, keep the hope up. This is not ready for the prescription pad today, but there's a lot coming up down the pipeline. For many of us, it's hard to move on from day to day. But there's a lot of hope, and it's very encouraging to see that a number of mainstream institutions are moving to advance this particular option. So hang in there, and let's keep working at it.
And thank you, Dr. Moreno, for one, joining us, and two, furthering the science, because I know you're kind of like one of the first people to really investigate this in OCD. And as someone with OCD, I really appreciate researchers when they do kind of the pharmacological heavy lifting to try to help out the community.
It's an honor.
Very cool. All right. Well, thanks everybody for tuning in as well. We'll see you next month.
Yep. See everyone.